1 minute. Fine.
So before I get the link, I would like to thank Dr. Shivaram Krishna, Mr. Sriram Venkatesh, Professor Kumar, and Professor Ramesh Babu for inviting me to talk on 3D printing and its applications in medicines.
Now you can share, sir, your screen. You can share your screen, sir.
Sir, I'm not getting the share screen.
Share you will get, sir. At the bottom, you will get share.
I think it got connected. I'm joining again.
You can share your screen, sir.
Oh, it's going somewhere, sir.
We are able to see your screen, sir. Thing is, you have to select the PowerPoint, sir.
Yeah,
Select
no, that's what I'll tell you the PowerPoint, sir. That's what I'm just trying to.
We are able to see your screen.
Yeah. You got my screen, yes, sir.
Yeah, we got.
I get the screen.
No, it is seen, sir. Your PPT is seen.
Yeah.
Right. You can go ahead, sir. You can go ahead, please.
So thanks for inviting me to be a part of this academic meeting after a lovely lecture by professor from IIT. In fact, as a non-engineering personality, I could understand a lot of things about 3D printing. So today I would like to share my experience about applications of the 3D printing in orthopedics specifically. So there are a lot of 3D printing applications in medicines. I'm restricting myself to orthopedics because orthopedics is mainly branch which deals with bones. And so a model will always make us life easier in planning the surgeries and contemplating the treatment. Now, I have received no financial support, so I have no disclosures to be made, and I have no potential conflict of interest. So whatever the work is done is my personal work. So I'm clear about it. Now, if you take the innovations in orthopedic surgery in the last decade, robotic surgeries have become very popular. They're making a minimally invasive surgery. The next scientific development was orthobiologics, that is trying to enhance bone healing in form of stem cell therapies and accelerating bone healing, scaffolds being used, and smart sensors are being used, like lengthening a limb. We are using sensors where they automatically lengthen the limb. So one of the most important revolution in orthopedics which has happened is the 3D print technology, especially for patient-specific solutions. I'm not going to. It's the process of making a three-dimensional object virtual of any shape from a digital model. So the digital models, what we use is, you create a model. The model is of the bone is already created by God. So we only take that model and print it out and use it. So we unlike the previous speaker has said, we cannot modify the model. Model is model. That's bone is bone. The shape is same. So we are only whatever we do, we only trying to get the print out of it. There's a lot of articles have come, a lot of journals have come about 3D printing in medicine. There's a lot of hype has come. Now, basically, now 3D printing orthopedics, I would be discussing in the following. Now, first thing is it a hype or a reality? Is that really 3D printing there's so much of hype around the 3D printing. Does it practically translate into clinical use, or you are just trying to make it? So somebody, when I presented a topic, somebody asked me, the 3D printing model is a toy. I said, it's not a toy, it's a tool. So there's a controversy now. Is it a toy that we're making a model and seeing and enjoying it? Or are we using this model to practically use it and help the patient or help the surgeon in doing a better surgery? So the third thing is, it is a disruptive technology. Like, is the 3D printing going to drastically change the way we are looking at orthopedics or treating the patients? Or fourth is, are we playing God? Or the 3D, we are printing organs. Are these organs what we are printing? Are they going to function and replace the organs which are damaged, so that we are like God printing organs and giving that? Is that so? Are we reached that stage, or is it still high? Then a lot of people are talking about 3D printing, especially the FDM printers. Some of the FDM printers, at least most of the riprap printers, are all open printers. We don't know what is the toxic material that is coming out of printing, especially when you print an ABS plastic and then with a 230 degrees centigrade. So what are the health hazards of these open printers? Because each printer is being used now for an object to print, at least in medicine, 6 to 8 hours. A lot of schools are also having printers. So are these printers safe, or do we need to have a scavenging system for these printers? What are the health hazards? So these are the things, right? One of my professors, Professor M. Tuli, he used to say the present day clinician is obliged to the knowledgeable and should be able to shift the information as whether it's advertorial, like somebody is doing a 3D printing and saying it's an advertisement, or is it trying to promote his machine by saying that you can make all these things, or is it imagining that I can print this and do this, or actually is what being printed is practically of any use to the clinician. So as a clinician, I'm more interested in what way I can use these 3D printed objects to enhance my patient care. Does it really help? So there's a lot of hype was there. Now slowly the hype is settling, dust is settling down, but certain areas it are restricted. So I would like to share my experience of using these 3D printer models for the last 5 years. First printer I had was in 2014 when the patents just expired. And then with a lot of experimentation and learning on myself, so we could produce models and use. So I'll take you through what all the areas where we found the 3D models have made a difference in our clinical judgment and treatment. Now, most important thing to take in orthopedics, why 3D printing is more popular in orthopedics is mostly dependent on imaging. So based on the images, we take a lot of decisions. We see the X-ray, we know there's a fracture, we decide what pattern of fracture is there. Then we decide which surface we have to put a plate and fix it. So it's more of mechanics in orthopedics and less of biology. Biology is all theoretical, but most of the orthopedics, the surgery and fixation is mechanical. So for mechanics, we are all mechanical, our whole mechanical thoughts run around the bone, which is a hard structure. So that is the reason probably 3D printed models are very useful in orthopedics rather than in general medicine or neurology, where you don't need a brain model to decide. It's more of thinking and physiology. Here it's more of mechanical. So that's the reason probably. So whenever we see an X-ray as an orthopedic surgeon from a simple film, which is two-dimensional, we make a three-dimensional image of that fracture in our mind and decide an appropriate line of treatment. So for a senior experienced orthopedic surgeon, from a 2D image of an X-ray, he can easily make out a 3D representation. But for a young orthopedic surgeon, a lot of times they find it difficult, especially in complex bones like pelvis, which is not straight, it is curved in many directions. So for them, probably the 3D models are the ones which help them better planning and executing the surgery. Now, this is what the history of the imaging what we have. So the X-rays was first discovered in 1895. That changed the whole way we looked at orthopedics. And again, the major breakthrough came in 1972 when the CT scan was first made public. Again, in a CT scan, you get coronal and axial and sagittal. 3 plane sections are there. And the surgeon is to see 3 planes in 3 different films and make a computerized 3D model in his own mind and imagine and plan his surgery. Again, in 1988, another revolution has come where this problem of surgeon imagining a 3D model in his mind is eliminated by a software which converts these 3 things into a 3D model. But again, this 3D model, which is on your screen, can be rotated and seen. But again, you are seeing a 3D model on a 2D surface. So again, it does not give in-depth knowledge of it. But the whole thing has revolutionized in 2014 when most of the patents of 3D printing expired. Then the machines became accessible, and there's suddenly a rush of open source softwares for segmentation and other things. The whole picture changed. So now with the 3D model, we don't not only have a 3-dimensional concept, we can also feel the model. We call it as haptic sensation, tactile feeling, and exactly decide what we are going to do. So that's a great change in the imaging from 1895 when the first X-ray was discovered to the present day. Now this is the 2D image. As I told you, again, this is a 3D image. Again, this 3D image is again seen on a 2D screen. So though we can, in a computer, we can rotate it and see, but you can never get the information like what you get. The same knee fracture here, I can remove one bone and see exactly where it is there, which plane it is fractured. So this is the big advantage we got when we first saw the plastic. Now, once we can make a model of the patient's fracture pattern, the next question is now, what way can we use these models? So first thing, before we decide whether to use the model, the first question is, are these 3D printed models accurate? as the parent bone from which CT scan you have taken and printed the model. If the models are not accurate, if they're big in size or they're small in size, or if there's a difference in shape, then there's no way we can use this model for clinical application, because it's a waste of time, because it does not represent the actual patient bone. So first foremost thought what we had is, we should make sure that the models are accurate. So to know whether the models are accurate or not, we did the first experiment. That is, we took the dry bone from the anatomy department and we printed it to see whether it is accurate or not. So this is one humerus, this is your arm bone, and this is multiple. So when we printed, from the look of itself, the bones, at least the shape, they look normal. And then the other thing what we are interested in 3D meeting, is this 3D print reproducible? Like from one file, if I have to make 10 bones, are the 10 bones going to look the same, or first one will look good and the last one? So with this humerus, we printed 6 with the same one file, and we found that the shape of the bone is exactly like the parent. So one of our criteria is satisfied, that the bones printed, the 3D printed bones, look just the same in shape as to the parent bone. That is one satisfied. So one criteria which you are satisfied. The next criteria is, if you take a measurement, are their size is same? Even if there's a difference of say 0.5 centimeters, or if the difference of more than 2 millimeters in the size, we cannot use the model for our surgery or for templating. So what we did is, we went back to the anatomy department. The whole skeleton, we did a CT scan. All the bones of the body are scanned, and all the bones of the body, that is 206 bones of the body, we 3D printed them with a FDM machine. So this is one example. This is a thigh bone, femur bone. That's the left side. The brown one is the actual bone. The right side, the white one, is the 3D printed bone. Similarly, on the right side, you have the tibia bone, that is the leg bone, and the white one is the tibia printed bone. And if you take, this is the arm bone, that is the forearm bone, that's another forearm bone, and curved bone, clavicle, and an irregular shaped bone, calcaneum, irregular shaped bone, talus, irregular shaped bone, small bones, like very small bones of 2 centimeters, 3 centimeters metatarsus. So the whole skeleton we have printed, and we have now the whole skeleton and the 3D printed skeleton. So we thought we will measure and see whether the printed bone is exact the size of it. So we took the standard measurements available for us to measuring the bone. So all the bones we measured. So almost about 200 measurements we made in all the bones, and try to analyze to find, and we did to the statistical evaluation to see whether this is one example of a humerus. What are all the measurements? So 2 people have measured the bones so that to eliminate the intra-observer or inter-observer variation. And then this is how we measured. This is called osteometric board. You can see here the humerus bone, it is on 12.5 here, and it's almost 12.5 there. So the length of the bone is measured by this osteometric board, and we found that the bones measured are exactly, the printed bones are same as the original bone. Then we measure the diameters. We use the standard Mitutoyo scientific digital caliper, and we measured all the measurement. As you can see here, the head of the radius, which is 19.61 millimeters, and it is 19.6. That is 0.01 millimeter differences. That error could be because of the measurement error also, because the point, even if point of placement is a little different. So like that, we measured the irregular bones. We all measure the diameters. Then again, this elbow measurement, this is 57.78, and this is 59. There's a little difference here, and 9.48. So all the bones, 200 measurements, we have taken all the bones. Each person has measured it twice, and 2 people have measured it at 2 different times to eliminate. And then we analyze the whole result. And once we analyze the 4 bills, we found that the 3D mental models are very accurate. The overall difference, if you take between the printed model and the original bone, it's 0.01, which is, we feel from the treatment and templating point of view, it is significant. Any difference less than 2 millimeters, it doesn't affect our planning on those things. And here we have found the difference of 0.04. Probably the printed objects are 0.4 mm larger than the original. Otherwise, I would say it's about 1% larger than the original one. This could be the reason, because these models, what I've printed, I have all printed with FDM and using ABS plastic. So after the melted plastic, when it settles down, I think it'll expand a little, and that's the reason why that 1 millimeter or 0.4 millimeters difference. But that difference is not significant for us to use this model. So the first experiment, what we did, find out the accuracy, and we proved that the 3D printed models with FDM machine and ABS plastic are very accurate, and hence they can be used for whatever purpose you want, at the teaching, training, or treatment, or simulation surgery, which I'll tell you what once we have confirmed this accuracy, we try to use them for different purpose. So this is the article, this is the first publication we did on 3D printing in orthopedics in our scientific faculty. We did an error analysis and found that the fused deposition models of 3D printed FDM models are very accurate, and we published it in 2018. Now, once we have confirmed that it is this thing, then we started using it for clinical application and practically using this. So next is where do you use? So I would say the applications of 3D in orthopedics. Now we have, I put it as two applications. One is actual application where we have already used it and where we have found it very useful. Other is the potential, that is future, where we can use these models or where we can use this technology to enhance orthopedics and enhance planning in surgeries. So potential future is one where probably it's an evolving thing where we need to have collaboration. This is the area where we want to have collaborations with the universities so that we can further take the 3D printing. The actual users are already we have applied to our orthopedic practice, and I'll show you examples like what we have used. So I would say the models, first thing, the models we use are useful for, I would say, 3T, that is teaching, training, and treatment, and 2R, that is research and rehabilitation. So this is what we have been using the models for these 5 subsets, and I'll show you examples of where we are using. The first thing is coming to teaching. Now, normally whenever we teach orthopedics, we teach from the textbooks where they're all 2-dimensional images. But bone in orthopedics is a 3-dimensional structure. The 3-dimensional model allows a much greater understanding of the capacity. Okay, and also we can feel the model, we can feel the surface, and we know where the roughness is on, which cannot appreciate in an image on a 2D screen or in a textbook. So I'll just use a simple example. So this is one of the tibia fractures. This is the classification we have. The knee fractures are classified into 6 types, and this classification is based on the displacement of the pieces in 3 dimensions, which you can never appreciate in an textbook diagram like this. So what we did is this all 6 types of fractures from the patients what we had, we made 3D printed models. So now I have these 3D printed models. Now you have a fracture on a line diagram in a textbook, and you have the real model, which is the same type of fracture. Now the student seeing at this model, he can rotate it and have a better understanding of the fracture pattern. So we started teaching the students on the classification, not only based on the textbook, on the models. Now, after we made them learn on the models, then we put a test to them. The next time when they have a similar fracture and X-ray, the student is able to better classify them because his visual perception and his imagination has drastically improved because he was able to contemplate the models what he has seen. So these models have really helped them in better understanding and better classifying them. So like that, this is one example. I'll show you another example. Now this is a pelvic bone. So this is one classification of Paprosky where there are 6 types of classification. It's very difficult in this diagram to understand what is type A, type B, type C, and type C. So these are classifications based on the amount of bone defect or bone loss that is seen in the bone in 1 view and 2 view. There's no third view in this thing. So if I tell this is E where there is a loss of acetabulum and there is like this, it's difficult for them. So similarly, again, all these 6 types of pathologies from the patients, we printed 3D model. Now this is type 1, type A, type 2, and type 3. Now you can see this is the model, this is the classification line diagram, and this is the model. Now with this model, the student is able to better understand what exactly you mean by this type A. What he has written as a description, he is able to understand it better, which is otherwise very difficult. Now this is very difficult to imagine that this is like this. Similarly, if you go to the other classes, again, this all. So the whole classification system, especially in curved bones and where the classification is based on 3-dimensional displacement or loss of bone, it's very easy for the student to understand based on this model. So we started all classifications of orthopedics, all classifications of all fractures. There are about 200 classifications of fractures. Like I showed you, these are the 2 examples. So all classifications, all fractures classifications. Now we are going to print them from the actual patient's fracture from the CT scans models. So we are going to have a classifications of models of all classifications and a library, so that the student next time when he reads a textbook line diagram, he can always keep a model to it next to it and understand better what the classification and how it's classified. So we are going to have a library of 3D models of all the fracture patterns existing and classification. So that's going to be a big boon for the PG students, where they have a much better understanding. Project is already started. We have just completed about 20 models, 20 types of fractures. So probably it's a 2-year project over a period of time. So this is going to be a permanently anybody tomorrow. It's very easy for them to understand. So this is one of the very potential use of 3D printing models from the actual patient's fracture. So that now the student has an X-ray, student has a CT scan, and the student has a 3D model. So by reading all the three, he'll have a better conceptual understanding of what that fracture pattern is. So that in future, when he has no facility for 3D printing, even looking at a CT scan, because of his experience in seeing the models, he'll be able to better understand the CT scans. So this is one potential area. Similarly, this is another model where we have made in the hip. This is a dislocated hip, which is very difficult to find out in X-ray. And if you can see here, the cup is very shallow. That's why the head is gone out of here. So these type of things in X-ray, we draw some angles and say if this head is above the angle, then it's dislocated or not. But that's again a difficult proposition to understand. But when he has a model, he knows, right, this is dislocated hip. So the teaching becomes easy and teaching becomes much more practical and efficient by using models to teach, which is probably internationally accepted. Anything that is taught with a model always gives a better understanding. Now, next is where we can use the model for training. Now, we all know practice becomes perfect. And in orthopedic surgery, or for that matter, any surgical branch, it's the training of the surgical surgery which ultimately make them a good surgeon. Now, unfortunately, now there are a lot of procedures which are new procedures which are done and which are minimally invasive procedures are done, where we never allow a postgraduate to do that. So all the time, what he does is only assists us and tries to learn from seeing what we are doing. He never gets an opportunity to do, because we are operating on a live patient, so the patient always needs to get the best treatment. So whenever there's a surgery, the best surgeon in the theater available will operate, not the student. So that's the standard teaching. So students have to learn only for this. So this is one drawback for us in trying to teach students minimal invasive surgery, because we cannot allow them to operate. So the next question is, suppose if we can make a simulated model of the same patient's fracture, then I can operate on the table and he sees, then he can operate on the model subsequently at his leisure time, so that he has seen me operating and then he does the same thing on a model, and I can also compare with him. So we started, why not we make a model so that what he practices on the model, subsequently it can be transferred to the theater when he becomes a consultant. One example I show, this is one surgery where we do, this is a fracture of the scaphoid bone. And then for this bone, we make a small opening in the dorsum. Through the small hole, we pass a guide wire. And over the guide wire, we drill and we pass this screw and bury it. So we don't see the bone at all when we are operating. It's all done through the small hole. This is a percutaneous fixation of the scaphoid. Now, this is not a very frequent surgery. We do this surgery once in 2-3 months. So for a postgraduate to do this training to this surgery, he never gets an opportunity to do it, because we don't allow him to do on the patient. Only thing he assists, when he assists, he cannot see or feel anything, because everything is done through small hole and everything I'll be doing. He'll be just holding the retractors for me. So what we thought is, now why not we make a model? So we took a CT scan of the hand. Then these are the carpal bones which we printed. This is the scaphoid. Then we printed the metacarpal bones separately. Then we made the hand, that is the wrist, and these are the metacarpal bones. Then we printed the other two bones. So this is the complete wrist we have printed, 3D printed complete wrist from the CT scan of the patient which we have operated. Now this is exactly this bone size, shape, and exactly is a replica of the original patient's hand. Now I have patient hand which I am going to operate. I have this model which my PG is going to operate. Again, when we are operating in this model, I don't see the bone there, but here I'm able to see the bone. So I have to cover this and make a wrist there. So what we did is, we printed from the same CT scan, we could print the skin of the wrist of the patient. Now this is again by thresholding, changing the threshold from the CT scan, we eliminated all the bones and soft tissue and got only the skin. And this is a 3D skin printed. This 3D skin printing, we did it with the ABS soft material, because We want it to be flexible. As you can see, this is the wrist and this is the dorsum. You can see the veins also exactly like what we have. This is the model. And this model is hollow, so that we can put the bones inside and cover it. So this is the hollow we made, and this model is again flexible. We are able to bend it and do that. And then once we did that, this bone model, we put it into this hollow model and we made a wrist. But still again, we have a plastic here, this thing here, and then we have the bones here. But again, there's a gap in between the bone and this thing. So when you try to operate on this, again, the bones will move inside. And then this is not very flexible for me to operate like the normal wrist. So what we did is now this whole thing is filled with silicone. So we used the lowest Shore 10A, which is the most soft, flexible silicone available. So that now we fill the whole thing with silicone. Now, once we have filled the whole thing with silicone, we allowed it to set for 6 hours. After 6 hours, we split the plastic shield cover, and then now this is my final. Now, this is a silicone molded wrist with bones, and I don't see any carpal bones inside. Now, this is the dorsal view and this is the volar view. Now, this is just like the wrist of the same patient. Now, this silicone model, what we made, is very flexible. Like our wrist, we should be able to bend it. So this is able, we are able to bend it, and no bone is moving inside. Now, if you look at these two things, this is the wrist and this is the X-ray of the patient. And this is the same patient's wrist 3D printed, and this is the X-ray of the patient of the plastic bones inside. Now, this almost looks the same. This is the same patient one which I have operated, the same patient one which I'm giving postgrad to operate, because he cannot afford to make a mistake here. He can afford to make a mistake here, so that he'll learn on this. Once he's proficient on this, then he'll come back and he becomes a consultant to operate. Now you can see my wrist of the patient and his fracture, and my 3D printed wrist and his X-ray. They're almost exactly the same. The next is now, you can see this is the X-ray and this is. Now the question is, now I've used ABS plastic. That is the reason why my thing is not very clear. I mean, not as dense as this bone. Now we are trying out newer materials here. Now I have a wood plast material, which gives much more clarity and exactly same like this, but it's a little difficult to print because it's got wood and plastic. The wood is getting burnt and clogging my nozzle, so I'm not able to print. But anyway, I'm comfortable with this. It looks reasonably okay for to practice. Then this is the model. Then this is my postgraduate practicing on the model. He has put the wire and he has put the screw. So finally, this is what I have done to the patient, and this is what my PG did to the model. So almost he did the same level as me. So now I'm sure that my postgraduate, after seeing me operating for 4 times, he is able to do the same surgeries. Now after seeing this, I'm confident that I can allow him to do on a live patient. So this is probably the greatest advantage of 3D printed model, because every patient's specific pattern I can print and I can use it. Now this model, I can open it up and remove only this bone and put only this bone printed again and give it to another postgraduate to practice. So we are trying to use these 3D printed models now to begin with. So similarly, now I have printed the whole hand now. Now this hand is now under development. Now this hand also, I'm going to print the whole fingers in a ABS plastic and fill them with silicone. And then all this, I'm going to create a lot of fractures in this. And then I'll ask my student to practice fixation of this fracture. So 3D printed simulated models are exactly like the original patient's hand. So practicing on them gives them a better opportunity, a better learning thing than this thing. Because unlike other department, the surgical learning is only by observation or by doing the surgery. And unfortunately, we don't allow the students to operate. They're only assist. So only they get a chance to operate when they get qualified. So if you allow them, or if you give them an opportunity to operate on these models after seeing you operating an actual patient, probably I think it's going to make a lot of difference, and they will be more confident to operate once they get out of the college. So this is one of the greatest area where we found the 3D printed models for simulation surgery is good. So similarly, this is one we did it. There was a conference, which in the conference, the surgeon wanted to have 20 students practicing on the model. So we printed 20 humerus and gave it to him. So there was confidence. This is another model, which is again done for a congenital deformity of the foot for the students to practice. So a lot of models now we are trying to develop. Now we have started with the wrist. We are going to hand. This is for congenital deformity of the leg. This is for the shoulder. We are making models, surgical models for anesthetists to practice anesthesia. So a lot of simulated models which exactly replicate the patient's anatomy can be made from directly from the CT scan of the patient. We don't need any other material or anything. Like previous professor has said, the greatest advantage of 3D printing is you just need a machine and you need the software to make it. You don't need drilling machine, you don't need grinding machines, nothing. One machine does all for us. So this is the biggest advantage. Now, the third thing is, the most important thing is, are these 3D models are useful in any way for the treatment? Now, the treatment 3D models, we found them to be useful in three methods. What is the preoperative planning, templating, that is trying to make a mock surgery on the model to see where to put what, and then patient-specific certain things what we want. Now, preoperative planning, when it comes in a case, especially in a case like pelvis, the fractures, the so complicated. Sometimes it's very difficult for us to make a three-dimensional assessment. I'll show you an example. Now, this is an X-ray of the patient. This has got a pelvic fracture. Now, we can't make out much on this, but if you see in this 3D model, the whole pelvis, the whole femur, the whole hip joint is gone into the pelvis. Now, this is the normal pelvis. The hip joint is outside. Here, the whole base of the joint is broken and whole thing has gone into this thing. Now, this amount of understanding, like which way it has gone, which plane the fracture has fragmented, can never be made an assessment in any other form other than having the patient. This is exactly the model of this patient who has a fracture. Now, I cannot make out anything in this very detail, but on the model, I know now I have to pull this out. It's broken here, I'll put one plate here. It's broken here, I'll put. So I can preoperatively use the model and make an accurate assessment or accurate planning that this is what it is. I'm going to do this, and it's become very easy. So studying the 3D model, my preoperative planning has become very easy, and this is translated into cutting down the operating time, reducing the amount of blood loss. So that's again a great advantage to the patient, especially in this complex fracture, which otherwise after opening, a lot of decisions are taken where there is a lot of wastage of time. Here in the model, preoperatively only, the whole team sits and discusses what to put plate and where to put plate, and we select the plates and also keep them ready. So directly when you open it, there are no surprises. We know it is here, so we just go and push it out and put a plate and fix it. So otherwise, all these decisions are taken on the table after seeing the pelvis. So this is one of the biggest advantages of using models for preoperative planning. Same thing as I told you, this is the one. Then templating. Templating means now we need to, there are certain deformities are there. We want to put a cup that we don't know what is the size, we don't know what is the shape. So we make a template of it and take a decision on it. So this templating helps us in doing a precise surgery. I'll just show you an example. Now this is a deformity of the child by birth. This hip joint is dislocated by birth and this is normal. Now once this joint is dislocated by birth, I don't know what is, here I have so much of neck, 4 centimeters. Here I don't know how much neck is there because it's rotated. This is the head. I don't know what is the size of this head. I don't know. This is the cup is closed here. There's a false cup here. So to understand what exactly is happening, what should be the cup I should put, it's very difficult on this image, even on a 3D CT scan. This is one case, and this is a hip replacement is done. It failed. The cup has gone inside. I don't know how much cup has gone inside, whether the bone is there behind the cup or the bone is broken behind the cup. So planning, I have to remove the cup and put another cup. It depends upon how much of bone is there. So assessing the bone loss here and assessing the anatomy here is very difficult in 2D or 3D images. So what we do is we did 3D printing of this thing so that you have an object in your hand which can rotate 360 degrees and make an accurate assessment of what the loss is. Now this is the one case. Now the same thing we have done a 3D printing. You can see this is a normal hip. It has gone completely posterior to this thing. Then we know this is the size of the head and this is the size of the head. Then we did a mock surgery. Before surgery, on the model, the surgery is done. We determined how much should be the cut here. This was our plan. So we determined what size of the implant I should put it. Then we determined where the cup should be. We determined the size of the cup. We determined how much. So all this thing on the model, we have decided, okay, then we thought, okay, we are going to do like this for this patient. And then this model is autoclaved and kept it on the table. This is interoperative pictures, like what cuts we have determined on the patient, and we try to put it there. The size, this is what our printed size and this actual size, almost replica. And we use this model on the table. Then he said, okay, we have to drill like this, and we drill like this. So using this model as a template on the table, we were able to successfully put this thing, and this is the final outcome. We are able to perfectly placed at the same level and the same height is maintained. The cup is balanced. Now, this is possible because we were pre-operatively. The same thing earlier also we were doing it, but a lot of trial and error was done on the table. So we used to determine size and keep on changing it. So that is to take away a lot of time, a lot of bleeding. This surgery, because we have templated, we could finish it off in 1.5 hours with minimum blood loss. And once there's a minimum blood loss, a quick surgery, all your complications will be reduced. So this is one of the greatest use of 3D print models for templating before surgery. The other case, as I told you, this is the one we said we did a CT scan, but we are not very sure of it. When we printed a 3D model, we knew that the whole of the cup bone is lost. There's a huge gap. So now we are mentally prepared. Okay, there's a huge gap there. I need to put a different type of cup, not the regular cup, so that it doesn't go inside. Now, this information, I can get it only in the 3D model. I can never get it in the regular conventional X-ray to know, because I cannot remove the implant and see. Here, it's a model without any implant, so I know this. Same thing again. We have determined how much the cup size should be there. This is the cup and then filled with bone. And we have used this is called hydroxyapatite coated cup, the porous coated cup, where it integrates into the bone. A different design of cup, because here there's a bone loss, so we need to put that cup, and we put the cup, and then the cup was sitting comfortably. So again, the model was on the table for us to guide us exactly where we are going. And this is the final outcome. Now you see it's perfectly placed, stem is perfect, and this is there, and this is all protrusions eliminated, and we could exactly determine which way the screw should go. They should not cross here. That's all. So again, this is possible. The surgery was smooth, because there was no shocks or decisions on the table, because everything was predetermined. So these are the two examples of actually practically we used. Similarly, we have used the model. These are other cases where we have used the models, another defects where we have made the models. And this is the case of ankylosing spondylitis, where the whole hip is fused. The surgeon doesn't know where the cup is and where the head is. So in the model, we cut and decided how many centimeters from here we have to go, and then did the same thing on the patient, because in the patient, we will see only this part. Here we see everything, so it's easy to know what level you have to cut. Another example of a knee joint where there's a gross deformity. Another example of an elbow. It looks there is only small bone in front and back, but actually if you see the 3D printed model, whole elbow is covered with bone. So this is a very difficult case. So we decided not to operate on him, because we are not going to get any result. Looking at looks, it looks tempting to remove this bone. He's going to get movement. But after seeing this, we knew he's not going to. So certain decisions are changed after seeing the 3D print model. Otherwise, unnecessarily the patient would have been operated without any satisfactory result. Again, a spine, backbone, the spine, this is scoliosis, bent spine. In this spine, the problem is it's not only bent in one direction, it is also rotated. So when the object is rotated and bent, it's very difficult to imagine on the X-rays like how much of derotation you have to do and how much of correction has to do. So again, a model, so surgeon was able to decide on this, how much of rotation he has to do and how much of this thing, and they were successfully able to correct the deformity in this patient. And this is a polio limb. In an adult, the whole foot is deformed. Now we have used this model. We have to cut the bone here and make it straight. So we have to take out a wedge. Now we don't know how in operation we'll only see a part of the bone. So we have decided pre-operatively that this is the amount of. So we did a mock surgery. We removed this amount of bone and corrected it, and it was exactly corrected. So we determined the wedge, how much you take, directly went to the patient and took out the similar wedge and corrected. In one go, we were able to get 100% correction. Otherwise, normally we cut a little, correct, and see if it's not fully corrected. Again, you cut a little and correct it. So there's a trial and error method. So all these trial and error methods of correcting the deformities can be eliminated, because you can always do the trial and error on the model and definitely decide how much you're going to do and execute it on the patient. So this is going to be a lot safer to the patient, and our results are going to be excellent, and the complications will be minimized. So this is another area where deformity correction, 3D print models are very useful, where you can do a mock correction on the deformity before you actually contemplate operating patient, so that there is no trial and error on the patient. Trial and error is only on the model. Then coming to the treatments, the next important area where we found it is patient-specific custom guides. In certain areas, when you want to operate, we use guides to drill. Now, what happens when the bone is deformed and the bone is not normal? Conventional guides which the company supplies may not usually fit to the patient. I'll just show you an example. Now, this is the custom guide what I've printed. I'll show you. Now, this is a case of humerus, that is your shoulder, where the head is absorbed for whatever reason for fracture. Now, this needs to be replaced by a joint. So this is what we call as a reverse shoulder arthroplasty. Now, there is reverse shoulder arthroplasty has so many components, but the most important is this component, the base plate, which has to go exactly into the center of the bone. exactly it has to be in the center of the bone. And the bone is very, very narrow. You can see this. So it has to go, you cannot have a millimeter deviation this side or this side. And this is very difficult to place it because this diameter is about 8 millimeter and this diameter where it goes to bone is about 12 millimeter. So you have only 2 error on either side. So if this is not placed in the center, obviously the whole thing is going to fail. So what we did is now for this patient, as I told you, it has to be exactly in the center in all planes where when you go this. So your margin of error is very, very narrow. If you go a little that side, you go out here, you go this side, then the whole component will become loose. And this is the place plate body. So what we did is we wanted to make a jig so that you put the jig on that and put a hole into that. Through the hole, it will go exactly there. So this is what we call it as a patient-specific custom jig. So now this is what it is. This is the company jig. You put the jig and you put a hole, it will exactly go to the center. But this company jig will not fit most of our Indian patients, especially when this is deformed. Now, this is exactly what I'm saying. You need to point an entry here. Now, this is a very deformed one. So I don't know exactly where, if it is supposed to, if I go here and if it is wrong, I don't have a second choice. So I have to be very precise in exactly hitting the target only once. So what we did is now we made 3D printing model of the scaphoid. Then we determined where the jig should go. So we have determined this is where the jig should go. So we did a subtraction of that. And this is our template, which you overlapped it. And then this is my template. This is the surface which is embossed on this, and this is the hole. Now, this is the template what we have made. This is a very small template. And then now this is the bone, and this is the template. Once I put the template on the bone and pass through this hole, it's going to be exactly. Now I know my bone is exactly same. Now if I put on my real bone this template and go through this hole, it is going to go exactly the same. Now that's why I'm confident. So we put that and we drilled it and we saw that it is exactly in the center. So we are sure now my template is perfect. Then this is the template on the table. Now on the glenoid, I put this template and through the hole, I made a hole and it fit exactly perfect.
Sir, sir, you are not audible, sir. Hello, sir. Sir, you are not audible, sir. Hello. Okay, I'll be online.
unmute. Yeah. And then share just as
Now you can share, sir. You are in the. I'll share. I'll give the privilege, sir. This one.
share even, sir.
You can share, sir.
Yeah. One.
You can share, sir.
Yeah. Yes, sir. I'm sharing.
Continue. We are able to see, sir.
Yeah. Yeah. Now you're able to. So sorry for the inconvenience. There was a power cut, and then my thing got down. So, so these custom jigs are made specifically for each patient. So there is no other way we could have got this perfection in surgery if the jig was not there. The jig takes just about 20 minutes to print, and it just costs about 150 rupees, but it's going to make the life of a surgeon very smooth. Otherwise, by trial and error, they have to put it, and if that doesn't go in the center, the longevity of the process will be reduced by 50%. So these areas where the 3D printing jigs are very, very useful, and since you cannot, these are personalized and patient specific, all the more the 3D printing is more useful in here. The same thing, this 3D printed jig, again, we have published in our case reports, this thing, which is well cited. So these are the areas where the treatment point of view are very important. The other area where the 3D printing, especially the 3D printing of metal, is very useful is patient-specific implants. We don't have much experience with that. That's now we are going to start, and this is where the area where we want to have collaboration with the university, because we need a metal printers to print our implants. Now, this is a simple example. This is the pelvis where there is a tumor on this side. So the surgeon has decided to excise this much of tumor. Now, once you have excised this much of tumor, no company makes an implant like this. So you have to design an implant. So they have designed the implant for this after excision. And the same implant is 3D printed with titanium. And then it has been successfully implanted in the patient. So when you have an abnormal defects or when you have an abnormal loss of bone, where your standard available implants in the markets don't fit, you can always make a custom implant, design a custom implant, which can be 3D printed. And then this is another area where it's a very, very big boom for us to make custom implant. This is mostly useful in cancer surgeries, where each patient, the amount of bone they resect grossly varies from one individual to individual, and there is no uniform single implant. So each cancer patient has to have a different implant. As of now, these implants, whenever we want these implants, we send the CT scans to Germany, and then they make a implant and send it to us. Probably this is one area we need to work, and we should be able to do for ourselves. And as I told you, this is not a difficult thing. When we are able to make the models, our surgeon will tell what is it. So this is our next area where this is a very, very huge potential area, patient-specific custom implants for this thing. So this is what we call as a personalized medicine. Like each patient will have an implant which suits him the best, rather than having one implant for all. Similarly, the next area where we found a lot of useful of 3D printing products is the research. Now, as I told you earlier, each bone has its shape, and there's a lot of variation in the shapes of the bone, different ethnicities. Like our Asian bones are smaller, Japanese and Chinese bones are even smaller, whereas the American bones are huge and European bones are huge. So what happens is a lot of the implants what we have in the market, they are all designed to the size and shape of the Western population. So when we try to use those implants to our size, then we are finding it there are mismatches there. So the question is now we need to have an implants or which will fit exactly to our patient's sizes and shape, our population. Now we don't have a data. Now if you want to know the size and shape of our problem, like say if you want to know the scapula, that is the glenoid size and shape of Indian, no, we need to measure them. So we can't get these glenoids. Maximum, if you go to the anatomy department, I'll be able to get about 50 glenoids from the skeletons of the anatomy department. But 50 glenoids cannot be used to make a study to them. So now what we are trying to do is we are trying to print the scapula from the patient's CT scan, from the data which is not being used. If somebody gets a CT scan for a COVID, in that CT scan, the scapula is also involved. So I'm taking the data of the scapula and I'm trying to print the scapula. So like this, now we have printed more than 100 scapulas, and now we are trying to make a measurement on the scapula so that we will know exactly what is the shape. So this morphometric analysis, when you want large number of specimens to measure of our patients, knowing the age and sex, it's only possible with 3D printing. If you go to the anatomy, this bone, I don't know whether it's male or female bone. I don't know what is the age of the patients of this bone. So these two data are very important in morphometric analysis, and that can be only, we can get it when we print the 3D models from the CT scan. Now, the question is, now we can't subject the patient to the CT scan because radiation and ethical committee does not allow us. So what we are trying to do is morphometric studies. All the CT scan done for whatever reason, the unused data from the CT scans, we are taking the unused data and we are trying to print the bones to study this thing. Then the next question was that now, even if you want to take the unused data, the patient identity will be revealed. So now we have took the permission from the ethical committee. All unused data, we are anonymizing it so that when I get my CT scan, I don't know, there won't be any details of whose the CT scan is other than the sex and age. So we are anonymizing the data. We are using unused data and slowly trying to print will. So now I want to print 1,000 scapulas from the unused data from my department and measure them. Then probably that will be an accurate assessment of the size and shape. I cannot get 1,000 real bones to measure, which is practically impossible. So this is another area of morphometric analysis, probably 3D printing, especially when you want to measure irregular shapes like this, which is difficult to measure on a computer screen in two-dimensionally. If I want to measure the arc of this curvature, it's very difficult to measure on this two-dimensional image. So a 3D model gives me easy to measure it. Though there are formulas to calculate, this is an easier method. So this is another very potential area where we are using 3D models for morphometric analysis. Similarly, then comes to the rehabilitation. This is another area where there are these things, 3D printed processes. Now, earlier, whenever we want to give processes, it's a huge cumbersome procedure. They have to take an imprint of this thing, then they have to make a mold, then they have to make a processes. And these processes in children, especially as they start growing, every year the process has to be changed, and every time they have to go through the same cycle. Now, with this 3D printing, we are able to, there are different designs of processes available of open source freely in this thing. Anybody can download and print these processes. Now, you are free from design because somebody else has designed, so you can just download in 1 minute. It's very quick to print, and you can print on demand. If this gets spoiled, another one I can print it in 2 days to the same file. They're stronger. They're very cost effective. This 3D printed processes costs almost 10% of the conventional processes, and it's accessible. Like even in a small district where you don't have a big prosthetic unit where you can make a processes, you have a computer and a 3D printer, you can just download the file and print. And these 3D printers processes is going to be the big next revolution, especially for upper limb processes. There are a lot of, now this is a mechanical processes. Now they are also trying to add bioelectric thing to this and make a bioelectric 3D printed processes. Probably that will be the biggest achievement. So this is another area where 3D printed in rehabilitation in orthopedics is very, very useful. Now, coming to final questions, now I have told you initially these are the questions. Now, is it a hype or reality? I feel 3D printing and application medicine is a reality. May not be to the extent what the hype is there, but certainly it is helpful. And I would definitely say, as previous speaker also said, these are tools. The 3D printed models are tools for me to do better surgery and better care to the patient. It's a disruptive technology. To a certain extent, it's a disruptive technology, but still, surgeon has to operate, so it's not going to replace. Now, are we playing God? This is the organ printing. Now, this is a very, very ethical and time-consuming issue. As and now, I'll talk to you a little later about 3D bioprinting. We are no way near achieving any success. I feel probably it'll take another 2 decades before we get to really printing the organs, which can be used for function. I'll tell you the reason why it is. And of course, lastly, I'll talk to you later on about what the health hazards, what we found and what study we did about the health hazard of these things. Now, this is what I was telling you. Now, if you look at the Gartner's curve in 3D printing and medical applications, we are still here. We are still in the hype. Probably, I think over a period of time, it settles down. So now, it's been 5 years since we have been using 3D printing in medical applications, especially in orthopedics. So there's a big article where they have summarized all the published data available on 3D printing and orthopedics and did a systematic review. There are about 2,000 articles which are published from this thing. So a lot of hype is there. So once they did a thorough systematic review of advantages and disadvantages. So now what they found is there is definitely an advantage, but only the cost is prohibitive. Probably cost is prohibitive for Western country, but India cost is not prohibitive because we don't charge much for this thing. So obviously the 3D printing has a lot of advantage, but not to the extent of hype what it has created earlier. But slowly the indications are boiling down. The true indications are boiling down. Probably I feel in another 10 years we'll reach the plateau of Gartner's curve where it is definitive indications and definitive applications will be established. Now, future, what's we're going to hold? This is what I want to talk. bioprinting. Now, bioprinting is nothing but an extension of 3D printing. Instead of metals here, we are using cells and other polymers to fuse the cells. Now, the biggest problem with bioprinting is now a 3D model printed, we print a structure. We cannot print the blood supply to the model, and we cannot print the function of the model. And the function of the model is dependent on the blood supply. Now, the blood supply and function of the organs is very, very cruciate and very difficult to understand. And the blood vessels go into microns. So you cannot print a micron level tubule, patent tubule of some 1 lakh numbers in a 10 centimeter organ with a 3D printing machine as on today. But that doesn't mean that we are not going to achieve success. We are going to achieve. So that is the reason bone is the only structure which does not require blood supply when you put it in the body. Bone requires only shape and structure. That is why the first structure or the first organ which can be printed is an artificial bone which can be used in the human body. So this is what is this thing. So how to print an artificial bone? There are a lot of now bone scaffolds are being starting from ceramics to all those things. Now you take all these scaffolds and you mint it. So when you print a 3D printed bone, we need three things. The bone printed material should be porous like a bone so that the surrounding vessels will go inside. Then it should have enough strength to support the body. So these two things can be done. A lot of these materials help in getting at these things. But the most important thing what we found in this thing is now this is the tissue engineering. So what we are next is we print a 3D scaffold with whatever material, ceramics, hydroxyapatite or whatever it is. Then you add stem cells which can generate it from the same patients and add stem cells to it. And you have the growth factor, that's what's called the bone morphogenic protein, BMP. Now, once we add stem cells and then growth factor to the scaffold, it becomes a bone. It becomes a bone which is not living, but it's a bone which can be used as a graft or a substitute. So this is going to be the biggest revolution of in orthopedics, because of late, whenever there's a bone loss is there, we use the patient's bone from elsewhere of the body, the complications are higher, or use the bone from the dead body. Again, the complication and rejection rate is very higher because of antigenicity. Now, a synthetic bone printed to tissue engineering, probably this is almost near successful now. The clinical trials are going on. Once the synthetic bone is successful, probably it replaces a lot of things, like the whole blood bone banks which are there, they're all going to get closed. Because this bone, what you have printed, can be printed according to the size and shape of the defect what you have, and it is zero antigenicity, and it is living because you have added cell, and it incorporates because you have added protein. So probably this is the greatest, I would say, revolution, that is tissue engineering, building a synthetic bone. And we are almost, I would say, 80% on the way to achieving this in a standardized way. Now, once it becomes protocol is established, maybe I can print the bone before my surgery to the patient in my own hospital and then use it for the patient when we operate. So they're not depending on somebody printing and giving it to me. So this is another area. Now, in conclusion, this is only conclusion of this thing. Now, the 3D models, especially in orthopedics, in the last 5 years, what we found is it enhances the understanding of the disease. So we are able to better understand the fractures. We're able to better plan them and better plan it preoperatively. Now, this is translating into reduced operating time and better outcomes. It's very easy to educate my junior students so they are able to understand the concepts of surgery, the fracture patterns, and all these things. We are able to make a study of our own bones so that we can dictate the industry that this is the size of our bones and we need to have implants like this. A lot of foreign companies, foreign implant manufacturers are already asking us to give us the data so that they'll make specifically for India. They call it as Asia-specific implant. That means we choose the Asians. Then the cost-effective jigs, it's going to a very simple jig is going to make a big difference in a very highly complicated surgery. And of course, we can also use some of my surgeons use the model to explain to the patient what exactly the problem is and how to go about it. So this is one part of my talk where I've given you the applications of 3D printing on all things. Now the second thing is now a lot of times like the earlier professor has said, now you do a modification of your design so that your printing is easy. But in orthopedics or in medicine, I cannot modify the bone. Bone shape and model is given by God. So if I have to print the bone, I cannot modify the model in any way. I have to take the model in the same shape and size, but I'll modify my process of printing so that I'm able to successfully print that thing, what the bone is. So this is the difference between, so like in Android, you are able to cut the sleeves and get it attached to that. I can't do that. If there's a gap, I have to have a gap. Otherwise, the model doesn't serve my purpose. So I'll briefly tell you the protocol, what we have developed. Probably tomorrow in the workshop, they'll be telling you how to go with. This is what I call is how I do it. So when I got my printer in 2014, when it was novice and then there was nobody to teach us or tell us how to go about it. And I first tried to print my bone. This is what all I could print. It was all a mess. The object was falling off. It was not sticking. The nozzle got struck. So many issues because I didn't know the parameter. So subsequently, over a period of time, I've developed. So I have a simple protocol, which is very easy because here in medicine, we don't design the product. Like in CAD CAM, if you want to design, you design it. Here, I don't design. The design is already there. That is the bone. And the shape of it is already there. It has got its own shape. We cannot change the design. So what all we're trying to do is we are trying to see that how best we can modify the other parameters so that you successfully print that bone without any hazards. So this is the first, after 6 months of hit and trial, this is the first print model which I could print. I printed a small one. I was very excited about it. After that, I'll tell you about it. Now, this is the path what we follow. First important thing in medicine when you want to print models of bones, acquiring the data is the most important one. That is the DICOM files. Then you take the files and then you do a segmentation, that is create an STL file. Clean the STL file with all the artifacts which are developed when you're doing a CT scan. Then you do a slicing, there are a lot of parameters there, and then you do a 3D printing. Now I'll tell you the details what it is. Now, if you want to acquire files, there are different files, DICOM files which are available. We have CT files, we have CT angiograph, we have MRI and MRI. So each one has its own numbers. So to print the bone, it's very easy to print with CT scans. It's very difficult to print with MRI. The reason is MRI, you will not get maximum slices. You get 2 mm slices or 1 mm slices. Whereas in CT scan, I can get 0.62 mm slices. I'll tell you what that actually means. So the first thing is whenever you want to print a bone, always ask for a CT scan, not an MRI or a CT angio. So this is the best DICOM file to print a bone. Now, whenever you ask for a CT scan, if somebody says what type of CT scan you have, you need to have 3 plane images, that is axial, sagittal, and conal. So all CT scans are done in 3 planes. If you just tell the technician, he'll give you all that. So you need all 3 plane slices, and slice thickness should be less than 1.2 meters, and preferably 0.652 meters. So whenever, sir?
No audible, sir. No audible, sir.
No.
Audible, sir. Audible.
Right.
Continues.
Okay.
You can continue.
Audible now, sir?
Audible, sir. You can just press. Audible, sir. Audible. Sir. You are audible, sir. You are audible. Sir, you are audible, sir. Hello?
Sir, I'm audible now?
Hello? You are audible, sir.
Okay. So whenever, okay.
Sir, you press F5.
So whenever
sir.
you ask for a, okay, sir, I'm going. So whenever you ask for a CT scan, you need to have axial, sagittal.
Okay, sir. It's there, sir. Fine. Fine, sir. It is there. It's okay, sir.
Screen is there, no, sir?
Screen is there, sir. You can continue.
So screen and audible both are there, no, sir? Right. Right.
No, right.
So have a CT scan where you get sections in 3 planes and ask for slice thickness of 1.25 mm and preferably size increment of 6. Yeah. So if these criteria are met, then you will get it, because the final product of 3D printing is always dependent on the original data. If the original data what is acquired is not correct, there's no way you can edit or modify the data, because there's a scanned data, and unlike your other 3D models where CAD CAM you can play with them, in CT scan DICOM files we cannot edit the data. So that's the reason your initial acquiring the data to the CT scan has to be very important. Now, once you acquire the data, now you need to do create segmentation. You need to done and generate a STL file. So there are enough to convert the DICOM files to a 3D model. My favorite is Invesalius. This is a Brazilian government software which is freely available. It uses DICOM files. It does 3D visualization. It does 3D creation. It can do filtering. It has thresholding, and it is free. The best text is Osrix, but Osrix is limited to only iOS system. Osrix does not play with Windows. So a lot of people are very comfortable with Mimix. Mimix is another one which is useful. So it's an individual choice what you are used to. I feel for a novice, this is easy because Invesalius, I'll show you why it is easy. Now, Invesalius is a software which is a freely downloadable software. It is by the government of Brazil. Now it's very simple. You just go and import DICOM files. So it imports all the DICOM files, like say 400 or 500 files. Once it has imported DICOM files, you have axial, sagittal, and coronal planes. 3 films are there. Then you don't need to do anything. There's a button here. You just say create surface. Just click the button. It automatically creates surfaces. So there's nothing manually. So it's all automatic and auto segmentation. So this is especially useful for people who are not very good at doing segmentation. And if you're not happy with the segmentation, you want to edit it, if there is a thresholding is already there, you can always go and change the threshold and make a mistake. But usually that means what threshold is automatically good. And with one click, you get an STL file. Now, once you get an STL file, once it is ready, you save the STL file. Now, this has a lot of artifacts. Artifacts are there. These are all the things I don't want. So the disadvantage with Invesalius is I cannot remove these artifacts in this system. So what I usually do is, there's another MeshLab software, which is again a freely downloaded software. You take the image to MeshLab software, and then, sir, you able to hear? Hello?
We are able to hear, sir. We are able to hear, sir. We are able to hear.
Yeah. So
you can continue.
This is MeshLab software. You put it, and then it's a very user-friendly software. Then you can clear all the extra artifacts and get the final model to print. So you clear all the things, close all your troubles, and make it almost print ready. So this is what is this thing. So once this is done, then you have to print. So there are different technologies available for printing. So you have one FDM technology where you use thermoplastic, you have polyjet where you have polymers, and they have laser sintering where you use it for metals. So
sir, again audio, sir. Hello, sir. Again some audio problem, sir. Hello.
Now we hear. No, sir. We are able to hear, sir. Sir, able to hear, sir?
Sir, we are able to hear, sir. Right. We are able to hear, sir.
You are able to hear, sir?
Sir, please continue, right. Sir. We are able to hear.
Different technologies available. Yeah. So the different technologies, I'm very comfortable with FDM. One is the machine is cheap and thermoplastics are cheap and easy to do. And then only problem with FDM technology is if you have an irregular shape, you require a lot of supports to print this thing. Like get of these supports. So there's there you are modifying the model to get rid of the supports. Here I cannot modify the model. So I have an alternative method of getting rid of the supports. So now The next is once your model is ready, you need to do slicing. There are many slicing software available. Probably the best slicing software is Slicer 3.3, which probably they're going to tell you tomorrow. So I use Slicer 3.3 for slicing this thing. So the problem is now this is the bone which I have put it. Now, if I want to print that bone, it's very irregular. So I cannot print that bone because the threshold of overhanging is almost 180 degrees. So this it's not possible to print. And if at all you have to possible to print, I have to print with supports, either tree-like supports or a wall support. Now, I don't like to print anything with the supports for a simple reason. It is going to spoil my surface on which I'm going to work. Number two, it's going to take a lot of time and a lot of material to support to print with supports. So now, so to overcome this, so what I do is this is a NetFab, again a software which is freely available, the basic version. So I go to the software, I slice my thing into two pieces. Now this pelvis, same thing, I've divided into two. Once I've sliced these patients, this is one piece, and then so I'm going to print them as two pieces and then fuse them manually, which is very easy to do. Now once this slicing is done, this software also automatically helps me to optimize it by closing all the circles. Now I put this on this. Now this is straight. Now there is no overhanging or threshold overhanging more than 45 degrees. So once I do this, then I go and set my prints. So as previous speaker has said, I would go for a standard printing. I'd go for when I want to use the bone for a surgery, I go for 50% infill. Otherwise, I go 10% infill because I just want to minimize the time to print. And the infills, whenever I use it, I use hexagonal, what I have sewed inside. And I keep ABS plastic I keep 230 degrees centigrade as the nozzle temperature, and bed temperature I keep 110. And I always keep this thing that is overhanging threshold, like how far it will print without falling down. I keep it as 45 degrees, which is safe. Now this is overhanging is less than 45. I can directly and easily print this thing. So this is the FDM printer which I use it. This is the FlashForge one, which is simple, and this is the easiest one we do. So by these simple tricks, I'm able to print almost all my models, and I'm able to successfully use them with these things. The only thing is that the FDM printer takes a long time. So for me to print one pelvis, it takes about 24 hours. So I split into 4 parts, and 6 hours I print each one. And since it's the ABS plastic, there's no post-processing, and it's ready. So that's it. Thank you.
Sir, it's done, sir. Truly very amazing, sir. I think you are, I say, you are, it's truly amazing, sir. You are a doctor come engineer, sir.
So, sir, I'll close.
Yeah, you can keep it, sir. You can keep it, no issue. You can close your screen, sir. No issue. You can switch on your.
The voice is breaking, sir.
Stop. You can stop sharing, sir. You can stop sharing. Sir, you can stop sharing, sir.
Seeing where. Yeah, that's. Yeah, I'm just saying, sir, where stop sharing, I'm not able to see here in this.
Stop only you will see, sir. That only you can see. Stop sharing on.
Stop sharing. Yes, sir.
Yeah. Sir, you can.
Yeah, stop.
It is still in the share. No, it is still in the share mode only, sir. It is still in the share mode.
Your screen, sir.
No, but your screen, your PPT is still showing. Now it's okay, sir. Now it's okay. You can switch on your videos.
No,
Sir,
now I'm seeing Venkatesh.
Yeah, everyone is there, sir. It's okay, sir. No, it's okay.
Yeah, switch
It's
on the
okay,
video, sir.
It's okay, sir. Sir, there are few questions.
So that's
actually it is true.
Yes, sir.
You are on time, sir, on dot, and it's like you are not like a doctor only. You are a doctor come engineer, sir. So you have shown very precisely how to do modeling, everything. I think tomorrow's our speaker work is half done by you. How to do all this biomedical modeling, everything you explained. And now there are few questions, sir. This is I am going to tell the questions posted by the participants.
Yes, sir.
It is,
I think you can.
Tulasi.
Yes, sir.
Yeah, I can also make them panelists, sir. First, I'll read the question, sir. Tulasi, she was
Yes,
asking, "Hello, doctor. Are you able to hear me, sir?
Yes, sir.
Hello, doctor. I would like to know how to perform clinical trials if the
Yes,
implant
sir. I'm
is
able
made
to
up.
hear, sir.
Sir, your video is off, sir. Please switch on. Sir, please switch on the video.
Sir, my
Sir.
video is on, sir.
Now it's okay, sir. Hello, doctor. I would like to know
My
how
video
to
is on.
perform clinical.
On, sir.
Okay, sir. It's on, sir. I am reading the question posted by the participant, sir. I would
Yes.
like to know how to perform clinical trials if the implant is made up of new biocompatible material. What is the role of an engineer while selecting the material? Is there any limitation with age or if a patient is diabetic? Are you able to hear, sir? Hello? Sir, are you able to hear the question, sir? Hello?
Yes. You're able to hear me, sir? Hello?
No, please, sir. Go ahead with
You're
it.
able to hear me?
We are able to hear, sir. Please. Go ahead, sir.
Hello?
We are able to hear, sir. Please. We are able to hear, sir.
Voice is breaking, sir.
You are able to hear, sir.
Now the question of say now whenever there are two things now whenever we have you're able to hear me. I'm able to hear, sir.
Your
Hello?
voice is somewhat breaking, sir. Sir, your voice is somewhat breaking, sir. Hello? Sir, there is a problem with your sir. Voice somewhat. It is no, it's okay.
Shall I?
There is some lag of voice. Voice
Join again,
breaking,
sir.
sir. Yes.
Should I join again? It will be I think easy.
Now it is okay, sir. Now it is okay. Hello?
Then I think it will come correctly. I'll join again,
Okay,
sir.
sir. Please.
I'll just
Please do it. Please rejoin, sir. Please rejoin, sir.
hello.
Please rejoin. Sir, please rejoin, sir. Please rejoin. Hello?
No, I'll join again, sir. I think that will get connected. I think. Yes, sir.
Please do it, sir. Please do it, sir. Venkatesh, are you able to hear me?
Yeah.
I think problem from SAR side only, some internet connection problem is there from SAR side.
Now we're done. If clear on that, sir. Now it's clear. Now it's clear, sir.
It is clear, sir. It is clear, sir. It is clear, sir. It is clear.
Right. So now, see the
I
answer
am
to, I'll answer to that implant question. See, there are two things in implant when we want to try a new implant. There are two things. One is the implant design. The second is the implant material. Now, the implant design, we can always make an implant design according to our choice. And then, and once the implant design is made, there are standard implant manufacturers certified by the government. We can get the implant manufactured by them, or and then we can use it to the patient, whatever it is. Even the implants, what we can design even in the university lab, and we can use it to the patient with the standard materials like titanium and stainless steel. Why I'm saying this is earlier when we are doing surgeries, when we want some custom implants, we used to get them from DRDL because they had the technology, so they used to give us the titanium implants. With regards to the material, now, but the material, if you want to use a different material for implants, then we need to do a lot of experimental studies on animals before we get them to the operating table. So that requires a lot of permission from the government and ethical approval. So whenever we want to try new implants, new material for implants, we will have to do an experimental study, wait for 2 years for the longevity to the survival of the implant, and then get testing. So that's why we are not concentrating much on materials of the implant. We are mostly concentrating on the design of the implants because standard titanium and stainless steel have served the purpose and they work well. That's it.
also the suppliers are giving the biocompatible material directly
Yes,
approved
yes,
material, so there is no issue. Sir,
yes.
same person asked question, sir. Is there any limitation with age or if a patient is diabetic with respect to this material used for the implant?
No, most of the materials what we use that are inert materials. So standard materials what we use is stainless steel SS316, cobalt chromium. Then we have got molybdenum alloys. Then we have got newer materials now titanium, and then we have got other material. All these materials are inert. They don't cause any reaction. And then diabetes, age, nothing has got anything to do with things. In fact, the biggest controversy is now I put an implant and treat a fracture. The question is, should we remove the implant or not? So standard practice is we don't remove the implant because it's not necessary. It doesn't cause any problem. There are implants which are lying in the body for 40 years, 50 years, nothing happens. It doesn't, they're least reactive and no problem occurs. Only in joint replacement, when they did certain new joints, like when you do a joint replacement, we use high density polyethylene as a spacer. But this high density polyethylene, over a period of time, it gets worn out. So it gets worn out 0.1 millimeter in 5 years. So this debris is causing some problems to the patients. Otherwise, the stainless steel metal implants are absolutely safe. Nothing happens.
Sir, one person, Mr. He wants to talk to you directly.
Yes.
He is Mr. I think some Vinay Kumar Reddy. I am making you as the panelist now. So please, Vinay
Yes, sir.
Kumar Reddy, please switch on your video and go ahead. What you have the query, please, Vinay Kumar Reddy. 3DP 150. 3DP 150. Are you there?
Yes, sir.
3DP 150. Please switch on your video. You can ask. You can go ahead. You have some question regarding some PPRD patient. Please ask the question, please.
Yes, sir. Good afternoon, sir. I'm fortunate to see you, sir. I heard you with many number of doctors, but sir, actually, I'm suffering with my daughter problem. Since 7 years, she's facing a problem called PPRD, sir. Actually, she is 14 years old. At 7 years of age, she got a problem, and she's genivalgum is increased. So due to that, her legs was bent. So we did many tests regarding that, but she could not walk properly and all. So after that, we did genetic testing. So they told that she's having dysplasia, some kind of dysplasia. So that genetic report is showing a PPRD, progressive pseudo-rheumatoid childhood arthropathy.
Yes.
So, but after finding the problem, I asked the NIMS doctor that then what is the solution and all. Then they told that there is no solution, and after adult age, that means 18 to 20 years or some age, she needs a hip replacement.
Yes.
So we met many doctors in across India, sir, and recently 1.5 years back, Amrita Hospital, we got a we got information that even though we replace the hip joints, it will not give for lifetime. So you have to
Yes.
do permanent. So 3D printing is anything is better. Better for her or something like that. I want to know, sir, and I want to meet
No,
you
no. So it's
personally,
like
sir.
that's okay. Personally, so I'll answer to the two things now. See, there is something called disease. There is something called as a disability. Now, the disease is whatever rheumatoid what she has. There is nothing we can do other than medical treatment. Now, over a period of time, the joint gets worn out. Then it becomes a mechanical issue that the joint has become rough. So we need to replace the joint. Now, what we need to understand is, as I told you, joint has two surfaces rubbing against each other. So over a period of time, there will be wear and tear. So even including the best of the joints, now we are using zirconium and other newer metals with high density, highly cross-linked vitamin E poly surfaces. These are so all these things they last maximum for about 20 to 25 years. After 20 to 25 years, there'll be wear and tear like a car tire. It gets worn out. So we will have to replace. So that is the reason what we do is we try to postpone the replacement as long as possible. Now, the question of 3D printing role in these cases is now the second thing is the longevity of the joint is dependent upon how perfectly it is placed. Now, if this is a normal bone, everybody does it perfectly. If the bone is abnormal, placing the joint perfectly is difficult. So in those cases, my surgeon, what he does is he does a 3D print model of the pelvis. Then he practices on the model which position is best for the patient and then translates it into surgery. So that, as I told you, there's no trial basis on the patient. So you are trialing, you are experimenting on the model, and you choose the most successful. So thereby your longevity increases. So if the pelvis is deformed and if there's a bad thing, then definitely a 3D printing model helps the surgeon in planning the management so that whatever you do it perfect. There is no failure. Otherwise, normally what happens is without models, some compromise will be there. So the longevity will reduce by 5 years. So that's the only role it can play. Other than that, as of now, we are not able to pay. They are trying to use cartilage cells and print cartilage and all those things. They will all take at least 20 to 25 years before they come into practical use. That's my.
Okay, sir. Thank you. Thank you. I'll meet you, sir.
Yeah, no issues. Sir, you are muted, sir. You are muted, sir.
Sir, thank you, sir, for your answer to the Mr. Vinay Kumar Reddy. And one question is Vasist, sir. He is asking, he is actually appreciating very clear and precise presentation. Thank you, sir. I have a query. If someone met an accident that makes his or her bone broken to number of tiny pieces, then how will be 3D printing done in a single file? Is that useful when printing those, sir?
No, that's what again. Now what happens if the bone is broken into two pieces, when I print, I'll get two pieces. I will not get one piece. So what we do is we print, depending upon the number of pieces we print. Now, if it's a very complex fracture, what we do is we print, the print will come as the patient fracture is. Then after the print, we operate on the model. We put the bones together, we put a plate and see. So then we will see what size plate I need to put, which surface I need to put, what is the size of screw I need to put. See, earlier, all these decisions were taken on the table. We put a plate and if it doesn't put up, we'll take out, put another plate. We put one screw, which is not sufficient. So all that trial, what we do it on the table is all eliminated by operating on the model. So once I operate on the model, I'm sure I'm going to use this plate. This is going to be my screw. This is going to be this thing. So it's straightforward, you're going to do it. The only disadvantage in acute fractures, why we are not able to use fully 3D printing is, see, acute fractures, we tend to operate within 12 to 24 hours. For me to get a CT scan and print the model, it is taking more than 24 hours, unless I see day and night and print it. So my surgeon says, I'm not going to wait more than 24 hours. If you give the model, I'll use the model. Otherwise, I'll go and do it. So that's why, as of now, most of the time, 3D printing, we are using it for surgeries which are planned surgeries, where I can give them the model, they can plan. Acute emergencies, unless the technology improves where I'm able to print the 3D model in 1 to 2 hours, still it's the timing is restricting as things. Probably the laser printers will print faster, but it is cost prohibitive because again the cost factor is there. Now whenever I do my surgery, even this is again a 3D printing, it's an extra cost to the patient because patient is not bothered whether I do a 3D printing or without 3D printing. He's interested in surgery. So again, the cost constraint is there. So that is the reason certain complex this thing. Some simple straightforward fracture where the bone is broken into two pieces, we don't need 3D printing at all. Why waste? Only in complex, like pelvis is there, where it's very difficult to understand, we do 3D printing. That's it.
Sir, thank you, sir, for answering very detailed answer. Now, is Murali Krishna is asking, sir, in India, do we have permissions or certification for patient-specific implants to 3D print and implant in patient bodies?
No private player is allowed to print a 3D print implant except DRDO. DRDO has a permission. We get for cancer surgeries patient-specific implants from DRDO. Now, I don't know the reason why nobody is trying to do, because now if I want a patient-specific hip implant, they all go to Germany. They all go to Germany, and now this is one reason where my hospital now probably in the next 2 years. So we are spending a lot of money, and we are having a clinical trial research unit. So we are planning to spend about 20 crores, and then we are going to get all certifications from all the European and American companies to do this type of printing and testing. So probably once that comes, we can do it for us. As and now, the reason is we don't know. The two reasons. One is people are not designing the implant, so we give it to the company sends to Germany and gets it from the Germany. But otherwise, there's no need, because earlier implants printed in DRDL, titanium implants, we were using regularly for all our patient-specific cancer patients. That's it.
Okay. Thank you, sir. I hope Murali Krishna got his answer from our doctor. Now, other question is, Sitambaram is asking, what type of research can we do with bioglass material? It would be grateful if you mention a few or specific one.
Bioglass material is again a scaffold which can be used to this thing. So now one of the biggest thing where we can use a bioglass scaffold is, see, now when I have a defect in the bone, suppose there's an accident and the patient has lost 4 inches of the bone and is lost. Now, to bridge the gap of 4 inches, there are two options available. One is I take the patient's own bone and put it there in the gap, a bone which is not useful from the leg. That's one option. The second option is you take a bone from a dead body, our bone, and put it here. The third option is you already stretch the bone which is there. Now the fourth option, which is more exciting, is why not print that gap bone with bioglass, with ceramics, with hydroxyapatite. If you can 3D print that bone with bioglass ceramics, I can directly implant it without, and this 3D printed bone will never get rejected because there are no proteins and there are no allergenicity. So that's the breakthrough we are waiting, bioprinting of glass to the specific shape and size what I need. Probably that is the in thing now. So that is synthetic viable bone graft. That's what we call it as tissue engineering. Probably in a year or two, that's going to be. And similarly, we want to print bone with already antibiotic impregnated in it. So that when an infection, if I put that thing, this bone will release antibiotic and will not get infection. And the antibiotic will be released locally for months together. That is antibiotic impregnated 3D printed scaffolds. That's what we call it. So there we use bioglass and ceramics.
Thank you, sir. Kirtana Sima Kurti wants to ask the question, what is the process of validation if I have to change design of prosthetic plate of femur bone?
No, the question is now, whenever we design a plate, first thing is it has to starts to have some scientific scrutiny. Like, so there are two different things. A plate is different and a joint is different. Now let's talk about the plate. Now we are trying to design a plate for fibula based on our shape. Now once we design a plate, now we see that then the plate has to be printed and put to trial. So we do clinical trials of the plate. So before we do clinical trials of the plate, the material is what is important. If it's a standard material, we do print plates and this. Now, why I'm telling you this, every time a company gets a new plate, the Synthes company is there, they brought a new plate for clavicle. Nobody is questioning, we are directly using that plate on our patients. Now, who has approved it? Nobody knows. So similarly, designing our plates, and provided the plate satisfies the criteria, like it has to be, there are two things what we said. Either it has to be superior to the already existing plate, so that existing, or it has to be commercially cheaper than the existing plate. Third, it should be easily available than the existing plate. If these criteria are met and the material is standardized material, we list. So why I'm telling you this, a lot of the designs of the plates what we have, I'm sure if you get to the market, half of them are produced in Delhi in some small workshops of plates. I don't know how much they are really clean in their material. But there is no authority to check that, because one of the biggest reason what we find is if there is small stress in the plate, they tend to break when the patient starts weight bearing. So implant failure is a big nuisance for us. So that's the reason why we ape the Western implants, because at least we are sure that there is no defect. That's it.
Thank you, sir. Vijay Kumar Raje asks, which are the biocompatible material for ENT prosthesis, which is printable? ENT prosthesis. I think.
So ENT processes, in the sense, I don't understand what do you mean by ENT process. Now the
You
biggest
may be talking about ear like that, sir. Ear like that. Ear for printing ear like that.
In fact, what one of the projects which I didn't show it because it's not related to orthopedics. The one of the project we had is, now if somebody has an absence of one ear, now we want to put a prosthetic ear to that patient. So earlier, what they used to do is, now if you have right ear absent, they take your closest relative whose right ear looks like your ear, and then they take a mold of that ear, and then they make an ear and put it to. And once the ear goes, again the relative has to be called. Now what we do now is, we do a CT scan of the patient, right? And then you have left ear. We just click a button and the left ear becomes right ear mirror image. Once the mirror image has happened, we print a mold directly with ABS. And once we print a mold directly with ABS, we pour silicone into that colored silicone. And then that becomes an ear which is exactly replica of your left ear, which no other ear can match. And number two, the file is always there. Whenever the ear is spoiled, again 3D print one more this thing and put it. Now that is one way. Now the next way is, why do we need to create a mold and then print? Why not we directly print the ear with 3D? Now ear is very soft structure. So the softest material which we can print now is Ninja Flex. That's one manufactured by Fenner. Even that, if you take the ear, I think I'm a little technical, the shore hardness, what we call it is the softness of this thing. So normally our ear is 10A shore hardness. So the best of the material Ninja Flex, which is the most soft material to do 3D printing, is 50 shore hardness. So it will never match. So 10 shore hardness, you will only get it with silicone. So still, for a prosthetic ear, make a mold with 3D printing, pour silicone into that, 10 shore hardness, and then make an ear. And you can make any number of times and no discomfort to the patient. And it's not only that the patient need not come. You can just order the company, you send the file, they'll print it and send it back. Or you can have a printer nearby, like getting a printing from the commercial shops, as simple as that.
Thank you,
so
sir.
That we have done, sir, and we have printed ears. They are exactly perfectly ears. And these printed ears, in fact, we went a little ahead. After printing the ear, we printed the part of the skull where it's going to be there to know the thickness. So that we, depending upon the thickness, 3 millimeters, we put 2 millimeters magnets into the thing, so that you take the ear there. The ear also has magnets. The magnets are under the skin. You just put it there, it sticks to your ear. So you don't need a glue also. Every day night you can remove, wash it and put it back. This is the biggest advantage.
Okay. So Mr. Naresh, you want to ask some question? Naresh, you raise your hand. Please ask question. Please ask precisely what you want exactly. Please.
Yeah, so I have only one thing I need to ask. So, how can we qualify the orthopedic components which we have designed? So, how can we qualify them in strength wise? I have only one question, sir. How can we qualify the biomedical parts in strength wise? So, what is the procedure for qualifying them in strength, in factor of strength?
See, as I told you, Nathi, in orthopedics, we have three things which are used. One is we have used plates, which we put it on the surface of the bone and fix them. Number two is we have rods, which we put inside the bone and fix them. The third thing is we have joints, which are replacing the part of them. Now, the plates, whatever you want to design, it has to meet the standard that it suits the patient correctly and the material. Whereas if you use the intramedullary rods, again, the diameter and all those things have to be there. And if you design a new rod, then it has to be, first we usually, if it is a surface plate or a new design, we experiment in an animal. Usually, so in our hospitals, we have tie up with CCMB, Center for Cellular Molecular Biology. So we do that. Now, when it comes to joints, it's very difficult for us to do this, because once you design a joint, the joint has to be put to repetitive stress, like it has to go to the cycles of movement, say about 1 lakh cycles of movement, and then only after that you'll certify whether the joint, your design is working on. So that's the reason why that again, that stressing the joint, that facility only I think at IIT Bombay we have, nowhere else. So that is another area where we are trying to get the machines and the appropriate infrastructure to test the new plates and test the new. That's the how we are looking. So as of now, what we are trying to do is now, since joints and all the things different, let us at least make plates which fits to our. So to make plate which fits to my bone, I need to know what my bone size and shape is. So that's the area where we are working. One plate we have developed. I mean, it's still on the prototype, and then once we get it.
So thank you, sir, for answering that question.
Yes,
Now,
sir. Thank you, sir.
Thank you, Naresh. You are a very active participant. I appreciate that. From beginning, you are very interested. Thank you, sir, Naresh. Now I unmute Anmant Dora. You are asking some questions. That's the last question, sir. We'll finish up.
No problem.
Anmant Dora, you can switch on your video and please go ahead. Anmant Dora, please. I change your role. Hello, are you there? Are you there, Mr. Anmant K. Dora? I changed your role, please. So I hope he is not there. Are you there, Mr. Anmant Dora? He has raised his hand, sir. I was waiting.
Net connectivity.
No, most probably, sir. He may be having. So I am changing his role, sir. So I think no more questions from the audience, sir. It's a highly interactive session, sir. I think generally before lunch people will be hungry and angry, but now you made them to feel hungry for knowledge. How you can use it for the 3D printing for application, sir. It's I say it's truly a very informative, highly specific knowledge that you have shared it with us, sir. Now I request our director, Professor Sriram Venkatesh, to share his, because he's also listening parallelly, doing his control of examination work. I think that is the interest you made everyone to sit and listen to it, sir. Now I request Professor Sriram Venkatesh to please speak about. Venkatesh, are you there, Venkatesh? Hello, Venkatesh. Hello.
I think his mic is muted, sir. His mic is muted, sir.
I think I am calling him.
His mic is muted.
Venkatesh, join. Now, please, Venkatesh, please say hello, Venkatesh. Hello. Hello, Venkatesh. Hello. Hello. We have joined so many parallel. Venkatesh, hello. Hello. He's joining, sir. Venkatesh is joining.
Yeah, no problem, sir.
So
hope, sir, I think my talk was reasonably satisfactory to clear the.
Not reasonable, sir. It's what you, sir. It's a peak level, sir. You have shifted our program to highest level.
This is our practical applicability, sir. Because as I told you, there's a lot of hype, and the biggest hype is printing an organ. The reason why, to all the attendees, the reason why bioprinting is not popular is two reasons. One thing is, see, 3D printing does print a structure, but it cannot print function. Function has to be inherent in the organ. So for function to happen, you require blood supply. And number two, after you print the 3D print, let's say you print a 3D print kidney will die in 2 hours if there is no blood supply. So after you print in 1 hour, you should put it in the patient, which is probably very impractical. So you print now and then in 1 hour it should be transplanted to the patient where the blood supply comes. You print now and after morning you print and evening you transplant, it dies. So that is the biggest problem where we are not able to. And then after put the kidney has to filter. That is the function. That filtering is something which is beyond our thinking now to get that function. So that is the reason we are not able to get. Sir, Venkatesh, sir.
So Venkatesh, sir, please go ahead, Venkatesh. Go, sir.
Sir, thank you very much for enlightening all the participants, sir. Actually, I also witnessed the lecture. In spite of my busy schedule, I went to my ante room and watching because of interest, and you have shown medical, biomedical, engineering, and even the analysis. You are more practical, sir. Actually, what we wanted is this. People are talking about 3D printing, but you are doing a wonderful job and you are practically implementing it. So I think all the participants have immensely benefited from your lecture. And I don't know that you are working in this particular engineering area, being a doctor.
Passions.
And I was impressed upon the you have made it to two halves, and to avoid supports to prevent to protect the surface of the
Yes,
joint,
sir.
pelvis joint. What you call
Hello?
algorithms available, which will automatically calculate the support to reduce the excess materials used for the support, sir. Anyway,
Yes.
but it is time to work together, and we are also interested. Our center is also interested to collaborate with you, and definitely, sir, I am also there in the panel of what you call ethical committee
Yes, sir.
constituted by the Sunshine Hospital and also the CDFD,
Yes, sir.
NFTDC.
Yes, sir.
So they are doing all these legs and all by CNC programming.
Yes, sir.
So, but whatever it is, but we can validate with our 3D printers. Then we can go for CNC machines and all. That is a different issue. But sir,
Yes, sir.
I'm
Once.
impressed, sir. And
Yes, sir.
we, on behalf of Department of Mechanical Engineering, on behalf of CPDDAM, we grateful to you for delivering a wonderful lecture, which is unique of its nature because of mechanical and engineering. And shortly, we are going to host a 2-day workshop exclusively for doctors, sir. Definitely, we will invite you, and you have to share your experience with the doctors working in this area. So, with
Right,
this,
sir.
sir, we need to collaborate, and definitely after this, this will not be an end. Okay, this lecture is only a beginning, we can say.
Yes, sir.
So, and you, we will invite you, sir, to see our facilities at our engineering college. And with this remarks, now I thank the Dr. Sivaram Krishna for giving me summarize opportunity about Dr. M.S. Reddy, M.E. Reddy, sir. Thank you very much.
Thank you, sir.
Sir,
Thank you, sir.
thank you, sir. Thank you, Emre sir, for your
Thank you, sir.
highly knowledgeable, excellent session, sir. I think most of the participants want to ask some more questions. I think it's so interesting that they are putting so many questions. I will be sharing the email link of sir to you, so you can, because there is a next section coming up, so we have some time limit. So thank you very much, sir, for your very highly excellent and enlightening lecture. I think you can become engineering doctor also, sir. That is doctorate. You can be given your work can be made as PhD degree in engineering
No,
also.
no,
You can
no,
put
sir.
it to doctorate. That is the
Sir,
extent of
I'll tell you one anecdote. When I first bought my computer, so my classmate is an engineer. So I was asking him, how does this work? How does it? He says, when I come to you, do I ask you how do you operate? I say you operate and you operate. So this is a computer. You just don't ask how it works. You just work on it. That's what. That's what. So
But
sir, I can never. No, sir, I can never compete nor anywhere near the engineering faculty.
No.
It's your specialty. I am only looking at the
Yeah.
application part of it. Since the application part of it, since I found it easy to print myself, so that I don't need to depend on anybody. So that, and as the professor from IIT has said, the biggest disadvantage in 3D printing of medicine is I cannot modify the model. I cannot modify the model. Model as remains the same. Only I have to modify the technology of printing. Whereas in other things, you can modify the model and get an additive advantage. But here, the model cannot be modified. Modify the model, the purpose is lost. So that is the only difference.
We should have design for additive manufacturing in biomedical. That should be different design prospect that we should think. Not like a design for additive man for engineering, but there should be a different look together in biomedical field.
Yes.
It's definitely, sir. It is
So
going to help. Venkatesh.
what I find is, sir, we cannot have any design modification in additive manufacture from biomedicine, but we can always have modifications in printing. We can
Yeah,
always
correct.
have modification in printing, the materials, the speed of printing, the infill, the speed, the what do you call that, threshold angulation, threshold for falling of the object, supports. All this can be modified. That is the area where I think probably we can, I mean, the engineering people can work a lot so that uh, because model is model, and that again I always say to my patient, if your CT scan is bad, your model is going to be bad.
Correct.
So beginning itself, your data, as you said, garbage in, garbage out. If your garbage, that is your CT scan is garbage, then your model also will be a garbage. That's it.
Correct. Venkatesh, you want to say? You are raising
Uh,
your hand.
Sir, Dr. M.V. Reddy, sir,
Yes, sir.
I want clarification
Yes,
and
sir.
also of 3D printing. Yesterday, I have shown one video. It is from USA,
Sir.
showing that they have printed a kidney, but it is not
Yes, sir.
implanted. It is near to the biocompatible material. And
Yes, sir.
in Usman University, we have biochemistry department, and
Yes, sir.
they are doing a lot of research in the materials. What
sir.
we can do in future, we can if there is a scientist to produce the materials, we can print them as a biocompatible material. For example, a wound is there. That wound is scanned and how much flesh is required, and accordingly flesh will be 3D printed into the woman patient. So
No, sir,
kidney, sir,
that thing I'll tell you, sir. That one area where the 3D printing is successful is, sir, now
we work on
skin
it.
is there. Skin is there, sir. Now, from one skin cell, or say 1 centimeter of skin, I can culture and grow 1 meter of skin in a
Okay.
culture mat. So now what they are doing is, sir, they are putting the skin cells into the print head of the printer.
Yeah.
And they are putting the burn hand under the printer. So the printer is putting cells on the burn hand layer by layer.
That's what
That has come, sir. That has come now. That is what they are trying. That is, you culture the cells, put the cells in the printer head, and keep the burned hand part on it, and it'll put the cells layer by layer, and a skin is formed on the skin.
It's like
Previously,
tissue engineering, right, sir? It's
yes,
like tissue
previously
engineering.
what we used to do, sir, we used to take skin from somewhere else and put it on the burn area. Now, if the patient has 90% burns, then I have no skin from where I can take it and put the cells. So what they do is, among the 10%, 1 centimeter skin they take, in 6 weeks, they can culture 1 meter, sir. At 1 meter cells, they take it and put it in the machine. Instead of me putting, and this, it layers layer. That's an experiment we have done. And there are a kidney, but for it to function, and the kidney should take the blood and produce urine. Now, for it to function, that is the part which we are not able to succeed. Structure we are able to make. Cells are living. Functioning, we don't know. So, but that doesn't mean that we need to give it up. My feeling is, sir, it takes at least 25 to 30 years to successfully print a kidney and put it in the body, sir. My prediction. If earlier to that, we will
liver.
not, sir.
Any
Also, sir.
body.
Liver, kidney, heart, and heart is even more difficult because the moment that you have made a heart, it should start pumping. You just made a heart structure and it is not pumping. In 1 hour, it dies. So you make a heart, put it inside and put blood and it start pumping. That means the neurological electrical stimulus has to come. These are the issues which functioning is the issues which are very heart. You need an electrical impulse. From where do you get an electrical impulse in 3D? It doesn't come. Kidney, it has to produce urine. We don't know how this is going to produce. If the blood is flowing and kidney surviving, if no urine is coming out, it's a waste. Those are the issues we are not able to solve as and now. But obviously, there will be leaps and bounds in technology, and everybody is trying to work on it because that's the gold mine, I would say.
Yeah, it is
So
future.
Sir, I have one doubt, sir. You are telling when you take CT scan, the layer thickness that you are telling now, sir, is it only for orthopedic or for any human body? When you take bone, we should maintain same layer thickness, everything. CT scan.
No, sir. See, when they make a CT scan, usually CT scan is done at 0.65 this thing. Now, from the raw data, what they do is they make 0.5 mm sections and give you the Phillips because you don't need more than that. Per hour to diagnosis, we need 5 mm films. But if you want to print with 5 mm films, the surface will be very rough, sir. We will not get it. So that's why whenever I want a 3D print, go to the CT department and take out the raw data and make file sets. That's why each CT scan, when I want to put, say, one knee, I'll have 1,000 files in that. So that's why whenever you want to do a segmentation of CT scans and get a good one, you need at least 16 MB RAM in your system. Otherwise, with 8 MB RAM, it just gets hangs. And you want a good
layer
model.
thickness, layer interval thickness is very important. That is very crucial.
Important. And then we have rough images and smooth images. Rough images already we use it for diagnosis, sir. For printing, you take smooth images. So they're called B1020. Usually I use B20. B20 is the best smooth image for 3D printing. This we experimented and got to that conclusion.
Okay. So thank you very much, sir, for your very enlightening and I think highly interactive session. Still, people are putting so many questions, but I hope we're conducting, as Venkatesh said, we'll be conducting 2-day workshop exclusively for biomedical. Yes, we invite other people also to join because we are already going about time limit. So,
so you have another talk also, sir.
The next talk also coming up, sir. So thank you, Venkatesh, for joining in spite of your busy schedule. Thank you. Have a nice lunch.
Thank you, sir.
Right.
Thanks, everyone.
Thank you. Thank you very much, sir. Professor M.V. Reddy Garu, for joining here, enlightening us in all these aspects. Thank you very much, sir. So we'll be shortly meeting again in next our academic programs in our college. As Venkatesh said, 2 days program will conduct, sir. Definitely we'll take your advice.
Correct, sir. Not only program, sir. We will try to we'll work together. So it's a mutual benefit because you are on the technical side and we are on the
we are ready to help in the CAD modeling, design everywhere, sir. Finite element analysis also, and I hope.
First thing, sir, biggest thing, sir, is simulation models for surgery. That's the next big thing, sir. So we got to make all models, so every PG will practice on the model so that he's perfect before he puts his hand on the patient.
Correct. Thank you very much, sir. Thank you very much. Thank you. So, dear participants, I hope you had a very nice session in the morning. So please have a quick lunch and come back at 2:25 to join for the next session on dental application of 3D printing. Professor Sriram Venkatesh, if you are free, you can also join during that time. Hello. So we'll join at 2:25. Venkatesh, if you are.
Sir,
is it possible for you?
Sir, Sriram, sir.
ఇప్పుడు జాయిన్ అయ్యాను నేను.
అది ఆడియో రావట్లేదు సార్. నేను ఉన్నాను అప్పుడు మీరు ఇస్తున్నప్పుడు ఆ వీడియో కూడా కనిపించట్లేదు. ఉన్నారు, మీరు వినపడుతుంది కానీ నాది ఎందుకు అది రిఫ్లెక్ట్ అవ్వట్లేదు. జస్ట్ ఒక ఇంపార్టెంట్ క్వశ్చన్ అడుగుదాం అనుకున్నాను. సార్ ఉన్నారా సార్? 1 minute.
వెళ్ళిపోయారు. అప్పటి నుంచి అడిగాను, ప్యానలిస్ట్ కూడా చేశాను, మీరు ఏం మాట్లాడట్లేదు.
చేశారు అని తెలుసు నాకు. వీడియో ఆన్ అవ్వట్లేదు సార్. వీడియో అవ్వట్లేదు, ఆడియో ఆన్ లో వస్తుంది. ఇప్పుడు వినపడుతుంది, అప్పుడు వినపడట్లేదు. స్పీకర్
మధ్యాహ్నం కలుద్దాము.
సరే సరే, అలాగే మొత్తం ఉన్నాను సార్. సెషన్ అంతా ఉన్నాను సార్, A to Z.
Thank you. Okay, Venkatesh, will it be possible to join? Okay, I'll give it's possible you join. Okay, so one person, Mazaruddin, was telling, please provide PPTs and recording of the session of all the keynote speakers. Anyway, we'll be giving the recordings of all the sessions. We'll post in the YouTube link of our CPDM center, and as well as in Atal website will be posted. So PPTs, the individual speakers getting all these things difficult. So you'll get the recording of all the sessions. You can see YouTube. After this FTP, shortly we'll be placing that one. Thank you very much. We will all join at 2:25. Please have quick lunch and come back. I wish everyone will participate in that session. Thank you. All of you should. We are going to show you who is participating and who is not participating in the session. Certificates will be given to those candidates who are actually participating in all the sessions. Please. Thank you very much.